Next protocol with a change to it is the pediatric chest trauma protocol. I don't think a whole lot changed. So I think the biggest thing was pain management moved into the advanced EMT scope, but we'll start from the beginning and go through it real quick. Chest trauma can lead to several internal injuries that are often difficult to diagnose. A history of chest trauma should lead to rescuers to suspect a serious injury, and patients should be treated with that expectation. Three major chest injury syndromes can lead to rapid death, and they must be recognized and treated rapidly. They include the following: bleeding from a rupture of a major chest vessel, mechanical decrease of cardiac output. So this could be caused by tension pneumothorax, cardiac tamponade, or cardiac contusion with or without dysrhythmia, and respiratory distress, which may be caused by tension pneumothorax, flail chest, pulmonary contusion, or an open chest wound. If chest injury interferes with breathing, it must be managed during the initial assessment. Objects penetrating the chest wall should be stabilized whenever possible and not removed unless absolutely necessary for extrication or transport. So EMTs, you guys are going to do your trauma assessment and management. Make sure you expose the chest, look at it, listen to lung sounds, palpate it, DCAP, BTLS, right? We all learn it in EMT class. Signs of a flail chest may include paradoxical movement of the chest wall or crepitus of multiple ribs in two or more areas. In case of flail chest, you want to use positive pressure ventilation and consider stabilizing with ipsilateral arm and swath. So, a wound in the chest may be an open chest wound, especially when it presents with subcutaneous emphysema and air movement through the opening. Just cover these with a sterile occlusive dressing taped on three sides. Observe closely for signs of developing pneumothorax. Uncontrolled external hemorrhage from penetrating injury should be packed with or without hemostatic dressings when necessary. Advanced EMTs, you guys treat for hypotension with IV fluids as needed. You want to keep them above a age-appropriate systolic blood pressure and consider analgesia for isolated chest trauma. Paramedics, positive pressure ventilation may be needed, but is likely to worsen unrelieved tension pneumo. If a tension pneumo is suspected by mechanism of injury and as evidenced by hypotension, respiratory distress, and/or diminished breath sounds, or rapid worsening after initiation of positive pressure ventilation, perform a needle decompression with an over-the-catheter needle placed at the second intercostal space at the midclavicular line. If condition does not improve after decompression of one lung, decompress the other side as well. Initiate cardiac monitoring and treat for hypotension.